Hi, I'm Patti Barkey, and I'm here with Dr. Laura Periman, the dry eye master.
I'm Laurie Periman, Seattle, Washington, here with Patti Barkey, CEO at Bowden Eye.
So today, we're talking a little bit about Quidel and metrics within the practice. And as someone who's really worked hard on dry eye within the ophthalmic community as well as the optometric community, I think we've all learned along the way that metrics are so important. And Dr. Perriman, when you looked at it and you went out on your own to start this practice on your own, did you immediately think of Inflamadry and Quidel as one of the main metrics you should have in your standard of care for diagnostics?
You can't measure what you don't look for. You have to test for these things. The critical importance of inflammation when we're talking about dry eye disease cannot be overemphasized. Unless you do the measurement, you really don't have a firm grasp of just exactly how much of an inflammatory disease burden is present. And when we're talking about treating dry eye disease, it's absolutely at the epicenter. We absolutely have to get that thing under control if we're going to advance the patient's symptoms and findings of dry eye disease.
Yeah, one of the things I've figured out along the way with Dry Eye University and all the practices that come through Dry Eye University is the fact that sometimes the metrics are lost. A lot of physicians think that they can just simply look at an eye and tell what's going on with the eye, and that's just not the case. What we've figured out is creating a flow sheet where we have our metrics documented on the patient visits. We watch for a change in the speed, if that's what you're using to measure. We watch for a change in inflammatory. We watch for a change in osmolarity, and those things kind of tell us what kind of job we're doing with our patients.
I love that approach so much. The advanced diagnostics really are far more accurate and far more specific in helping you detail dry eye disease, the impact at the point of care, and also the impact of the things, the interventions that you do, the medications you offer, the procedures that you perform in clinic. You can watch those values normalize and improve with your intervention. So it gives you a really accurate starting place.
Yeah, and with standards of care, we often teach practices, standards of care are so important. And when you started your practice, I know you went out on your own and you decided, I'm going to do this dry eye thing and I'm going to take care of my dry eye patients in the community. What was your problem or solutions or easy tricks to integrate diagnostic testing into your practice, especially metrics and these lab type metrics?
Yes, I love that. And first of all, I have to thank you, Patty, for being such a strong supporter and encouragement of starting your own dry eye disease practice. Anybody can do this. And it's so rewarding and it's so interesting and fun, and patients really benefit from it. But I agree with you that the metrics that we employ are really important for capturing where that person is at baseline and tracking the response to therapy. You don't know where you are unless you've checked out where you started from.
Yeah, so in our particular practice, we always, with a new patient, will do inflammatory. And based on that score, we offer treatment to the patient. And then as we monitor them, we look and repeat the test until we get to a negative status, right? And when we get to that negative status, we're kind of cool and we're good and we're happy with ourselves and with the patient. But at what point do you then decide it's time for another inflammatory or another MMP9 test for the patient?
Oh, that's a great question, and I'm really glad you brought that up. And I'd be interested to hear how you handle it in your practice because you're so good about procedures and protocols, and I think that's really important. The time for retesting for me is tracking response to therapy, but then also if there's a flare up, like people are not uniform in their dry eye disease. There's exacerbations, there's remissions, there's other things that come to play. Maybe it's seasonal allergies, whatever this is, and that you can recheck your MMP9 in order to track how much control you have over the disease state. That inflammatory part just can't be overemphasized enough.
So I'm always looking for really super simple ways for our doctors and our techs to figure this out. And one of the things we put into place was simply that flow sheet, those metrics. We do the speed on every visit. When the speed starts to elevate back up in score, or the patient's signs and symptoms have elevated, it's time for a new MMP9 so we can monitor our success and the patient's success.
I love that strategy, and I think that's really smart because you're catching it on the uptick rather than after it's already out of control. So I think that's a really smart strategy. the way you've designed it the way you have. And it's probably much more sensitive and specific than waiting for things to get bad. Catch it on the early stage. So I really love that strategy.
Yes, and I think, I really don't understand why more practices haven't embraced this. I think in order to take care of these patients, we really need more practices to be like yours and like ours.
I think that's a great point, and it makes it actually easier. Some of our colleagues think that bringing on these advanced point of care tests, osmolarity and MMP9, slow you down, bog you down, make it trickier to see, but I have found the exact opposite to be true. I now have a much more sensitive and specific way of measuring the ocular surface disease state, the severity of the activity of what's going on, and it's fast, it's simple. You can use it to communicate with your patients. Patients really appreciate knowing that all the things that they're doing to control their dry eye, now they're coming into a physiologic range with their osmolarity. Now the inflammation is coming under control until you get to that negative point. And we actually save the strips, and it's so much fun to go back and show the patient exactly how much progress they've made. They can see it for themselves.
Yeah, I think, the practices that say it takes more time, in reality, you're right. It takes less time because now you've got credibility and you can actually demonstrate to the patient the success or lack of success and why we're moving on.
That's right, and also a more accurate way of figuring out, do I actually need to tailor on and add on more therapy? If you're not getting that inflammation load coming down, there's something that you're missing. Is there a comorbidity that you missed? Is there a new element that's at play? Having that MMP9 metric helps to reassure you and the patient that you are making progress on that inflammatory burden.
I think in summary, use metrics within your practice, use Inflammadry, MMP9, osmolarity, have a series of standards that are absolutely your benchmark for success.